Colleagues, firstly, let's check connection. Do you see everything and hear me? If yes, write something in chat. Colleagues, do you hear me? Do you see presentation? Okay, colleagues, I think that everything who wants to hear this lecture is here, is with us and listening. So let's start. First of all, I want to remember you that in T discipline there are several teams of emergency important. Yeah, the main number of these themes are mentioned in this slide, and of course, among these 10 emergency cases, the most important are laryngeal stenosis, nasal bleeding. These are two main situations with what we met in our practice. Foreign bodies of ENT organs and traumas of ENT organs. If foreign body of larynx lead to laryngeal stenosis, it is the same as laryngeal stenosis. And if traumas of ENT organs, especially larynx, lead to stenosis, it also may be a reason for laryngeal stenosis. All other positions are also quite important and potentially dangerous, but in most cases we have some time to deal with them. So today we are going to speak about laryngeal stenosis, yeah, or acute diseases of the larynx. Few words about anatomy of larynx just to remember, yeah. You know that larynx is the whole organ and consists of cartilages, membranes, muscles, and mucosa. The framework of larynx is laryngeal cartilages. Yeah, and you know and you remember that laryngeal cartilages are divided on paired and single. There are 3 paired and 3 single cartilages. 3 paired cartilages, it is arytenoid cartilage, craniculate cartilages, and cuneiform cartilages. And 3 single, it's cricoid, pterygoid, and epiglottis. And from the clinical position, these cartilages are the most important, why we will speak during this lecture. On this picture, you can see the localization of single laryngeal cartilages. Yeah, you can see epiglottis, pterygoid cartilage, and cricoid cartilage. Between this pterygoid and cricoid cartilage, there is a very important membrane or ligamentum. Yeah, it is cricoid-pterygoidum ligamentum or conic membrane. Why it is important, we will speak a little bit later. Paired laryngeal cartilage. It is arytenoid cartilage and carniculate cartilage. And here you can see small cuneiform cartilages. On this slide, you can see the most important laryngeal membranes. Yeah. Also, cricothyroid or conic membrane. Yeah, as you see on the previous slide. And here, it is pterygoid membrane which fixed os hyoidum to pterygoid cartilage. Levels of larynx or floors of larynx. Yeah, larynx as a pharynx has 3 levels. It is supraglottic or vestibulum of larynx. It is middle, the glottis or laryngeal rim, and subglottic. It is the space between inner surface of vocal cords to the first ring of trachea. Yes, and you can see that uh, larynx has a form of sandwich. Yeah. Uh, Here is a white part, here is a white part, and these two white parts are connected with very narrow vocal rim. And you can just imagine that uh, all air, yes, that is required for normal functioning of human being, yeah, is passed through this very narrow space, yeah. And of course you understand that if there are some problems here, especially here, it may very quickly lead to laryngeal stenosis and insufficiency of air in of oxygen in organism. So what functions has larynx? Yeah, it's of course firstly and main function. It's respiration. The second very important function for socialization, for social being of humans, it's phonation, voice production, producing, and protection of lower airways. Uh, Here, yes, you can see the larynx as we see it during laryngoscopy. Yeah. So what are the anatomical structures that we can see? Yeah, it is epiglottis. Yeah. Here is arytenoid cartilages under the surface of mucus. Here is plica arytena epiglottica. Here is sinus piriformis. Here you can see true vocal cords. Here it is false vocal cords or mucus. Yeah, and behind the arytenoid cartilages, here is entrance to esophagus. This is position of vocal cords on relaxed, when the vocal cords are relaxed, and here during the phonation. Yes, and you can see that normally vocal cords are symmetrical, are of gray color, and during phonation they firmly closed the entrance to trachea, in trachea. So how we can investigate the larynx? Of course, the most ancient, is, if we can say such method, it's so-called indirect laryngoscopy. Yes, it is the investigation when we use special laryngeal mirror. Yeah, this mirror we introduce to close to uvula. Yeah, and sometimes we press backwards uvula with this mirror. Yeah, we then we direct the source of light in this mirror. This source of light, this light is reflected downwards. Yes, and then return to this mirror, so we can see the structures of larynx. Yes, why it is called indirect laryngoscopy? Because we receive reflected image, not direct image, yes, but reflected. And also, yes, what we can see here, so it is epiglottis, vocal cords, trachea, yeah, true vocal cords. It's vestibulum cords or false cords, and some other anatomical orientiers. Yeah, it's, you can see retinoid cartilage. The most crafted, yeah, the most modern methods of investigation is direct laryngoscopy. Yeah, but there are few types of direct laryngoscopy. It is so-called this type of laryngoscopy is used only during some operations on larynx. Yes, because to introduce this type of laryngoscope in larynx, yes, we need relaxation of patient and we need artificial ventilation during this procedure. Yeah, and why it is done? Because we see the larynx without any image by your own eyes. So you can see yeah, vocal cords, and here you can see the part of tracheal intubational tube. And for observation, for some diagnostic manipulations, we can use optic laryngoscopy. It may be from laryngoscope, from optic can be used, or it may be rigid optic may be used. And of course, this procedure is not required general anesthesia, just maybe local anesthesia. Yeah, and during this investigation, you can see such picture. Yeah, it is larynx of normal. It's just normal pictures of healthy larynx. Also repeat that what we can see here. You can see the part of epiglottis, vocal cords, piriform sinuses. It is here is the entrance to esophagus and cartilages of larynx and ligamentum plica area epiglottica. It's fiber transnasal laryngoscopy, yeah, as it is seen on this picture. So, what is laryngeal stenosis? Laryngeal stenosis is a narrowing of laryngeal space which causes difficulty for air passing through the larynx, rapidly or gradually progressed. So yes, if we return to this anatomical picture of anatomy, yes, you can see, yeah, just I want to remind you, it is very narrow space, and this narrow space become more narrower, more narrow. So according to time of development, laryngeal stenosis are divided to fulminate, acute, subacute, and chronic. If we are speaking about fulminate stenosis, it is mean that asphyxia comes within several minutes or even seconds. And of course, the main reason for this condition is foreign body or laryngeal spasm, but of course more common is foreign body. Foreign body in larynx may appear due to several reasons. Of course, you must remember that foreign body more often are met in childhood, especially in small childhood. Yeah, and it can be if, for example, child inhaled some foreign body, or when a child eat something, the piece of food also may appear in vocal rim. Yeah, and from this position, the function of epiglottis is very important. Yes, because you remember that the main function of epiglottis is separating respiratory tract from digestive tract. And if a child, or if a human, if a person eat something and then swallow their food, in this moment epiglottis make a movement to close larynx, yeah, and in this way it protects the respiratory tract from food. And sometimes, especially in patients, for example, with severe damage of brain, this reflex is absent. Yeah, it is the damage in nerve supply of epiglottis, and epiglottis lost the possibility of movement. And of course, it may lead to situation when during eating or drinking the piece of water or the pieces of food may appears in lower respiratory tract, and quite often it may lead to aspiration and aspirative pneumonia. And you know that aspirative pneumonia is very severe form of pneumonia, and sometimes it is very difficult to treat some such situations. And that's why the patient with a severe brain injury requires in firstly tracheostoma, and secondly in feeding through the nasogastral probe or nasogastral zone, yeah, to protect respiratory tract from pieces of food. And here you can see the example of foreign bodies of larynx. And if we are speaking about laryngospasm, it is more if we can say in such a comfortable situation, because laryngeal spasm very often ends spontaneously without treatment, and it is very rare when laryngospasm lead to severe problems. But you must remember that this situation may be met. So, acute laryngeal stenosis. The obstruction develops from several hours to 24 hours. Yes, it is edema of different etiology. It may be allergic edema, or you remember, yes, such disease is so-called Reinke edema. It may be the edema due to some inflammatory disease. It says maybe false group, epiglottitis, photoperichondritis, neck phlegmon. It may be traumas, yeah, gunshot injury, thermal or chemical burns, or kicking in projection of larynx. Also remember such situation, because sometimes, because in this case, any laryngeal stenosis can develop very unpredictably, and sometimes we saw such situation when a patient received the kick, yes, in projection of neck, yeah, he appears in hospital. The doctor examine him, see nothing interesting, yeah, and this patient go home. And after a few hours, he returns to us in severe stenosis. Yeah, in this case, stenosis can be developed firstly due to post-traumatic edema of soft tissues, and secondly due to forming of hematome of larynx. And if there are some suspicions that trauma that of larynx was quite severe, or uh, if you predict that something may be wrong, yes, it is better to left such patients in clinic for some period of time to for observation. Also operation may be a reason for laryngeal stenosis due to paralysis of nervous recurrence caused by strombectomy and traumatic bronchoscopy or intubation of trachea. Yeah, you remember from anatomy that only one muscle enlarged. Yeah, vocal cords. So yeah, so make the vocal rim wider. It is muscle cricoarytenoideum posterior, and this muscle is supplied by nervous recurrence. And of course, if there is some damage of this muscle, of this nerve, it leads to paralysis of muscle, and it leads to so-called paramedian allocation of vocal cords. It is a situation when vocal cords are localized not here in this position, yeah, but mainly on middle line. And of course, it leads to narrowing of vocal rim and insufficiency of air and the clinic of laryngeal stenosis. And you remember that these nervous recurrences are passed through the superior ridge of thyroid gland, and during strombectomy or some operation on thyroid gland, these nervuses may be damaged. Or if they are not damaged during operation, if the patient have abundant formation of scar tissue after operation, these nerves may be involved inside this scar tissue, and also it may lead to bad function of this nerve. On this slide, yes, you can see and here on this slide you can see the such disease, yes, as epiglottis. So we will speak about it later, but you may see so enlarged epiglottis, yeah, very severe hyperemia of epiglottis. Here you can see the purulent focus, yeah, purulent spot. It means that it is the phase of abscess of the epiglottis, and you can see that in some cases the vocal cords may be enlarged in can be very enlarged and closed vocal space, and also it leads to laryngeal stenosis. And here you can see how enlarged epiglottis is looked on X-ray examination of neck in lateral view. Yeah, you can see here is epiglottis. Subacute stenosis. Subacute stenosis progresses during several days, up to 1 week. And the reasons for this type of stenosis is the same as for acute stenosis, but plus laryngeal diphtheria. While laryngeal diphtheria, because membranes that may obturate trachea and larynx is formed usually till the end of the first week of the disease. And chronic stenosis. The obstruction develops slowly for weeks, months, and even years. Yes. You must remember that in childhood, the most common reason is papillomatosis of larynx. Yeah, here you can see it is papillomatosis. Yeah, you know that papillomatosis is caused by papilloma virus. The most severe serotype of virus is 6 and 11. These types of viruses caused very severe papillomatosis with very frequent high frequency of recidives, yeah, and quite high level of malignancy in future. Firstly, you remember it is a benign tumor, but the currency of the disease is in a lot of cases is very is very bad, yeah, because of high recidives. And you understand that papillomatosis is treated only by surgery, and after a lot of episodes of surgery, the larynx, of course, it is not healthy larynx. There are a lot of scar tissue, a lot of fibrous tissue, and after a lot of episodes of operations, it also may be laryngeal stenosis due to scarring deformations. So what also may be a reason for chronic laryngeal stenosis? It is, of course, benign and malignant neoplasm, prolonged tracheal intubation. In countries with good screening, of course, malignant neoplasm are quite rare indication for tracheostomy. But unfortunately, many developing countries have no possibility to make in time screening of special group of patients, and it leads to situation when a tumor is quite big in larynx and lead to laryngeal obstruction, to laryngeal stenosis, and such patients appears in ENT clinic in stenosis that required emergency operation. Prolonged tracheal intubation also is an indication for tracheostomy, yeah, because you know, yes, that prolonged tracheal intubation, it means that the laryngeal, intubational tube is localized between vocal cords, and cuff of this tube, when it is filled with air, yeah, press on the mucus of vocal space, yeah. So usually the cuff of intubational tube is localized here, and prolonged pressure of such tube to mucus of larynx and prolonged presence of this tube between vocal cords lead to chronic trauma of vocal cords and chronic trauma of mucus of subvocal space. And very often this situation can lead to scar tissue formation of these organs and narrowing of uh, larynx due to abundant formation of scar tissue. No, and here you can see also when scar deformation may develop. It is after acute contemporary chondritis, traumas, and growth. And quite rare reason, but you must remember that it can be it is specific infectious granulomas, tuberculosis, lupus, and scleroma. So, what are the main symptoms of laryngeal stenosis? Pardon, let's continue. So, what are the main symptoms of laryngeal stenosis? It is inspiratory dyspnea, heavy and prolonged inspiration. Yeah, remember that inspiratory dyspnea, it is the difficulty with breathing in. It is the neck and thoracic muscle participate in the act of breath, retraction of supra and subclavicular fossa, jugular incisura, and intercostal space. Yeah, here, 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 and it is participation of muscles of neck. And pterygoid cartilage excursion downwards at breathe in and upwards at breathe out. To these main symptoms, as for me, it is right. It will be right to add also one symptom. It is stridor, yeah, or laryngeal noise. So stridor, it's noisy breathing. So and sometimes experienced doctors establish the diagnosis of laryngeal stenosis even without observation of patients and before observations because the doctor can hear how a patient breathes, and it is quite characteristic type of breathing, yeah, stridor. Also, what also may be met, it is respiratory rhythm impairment, voice changes, venostasis, paradoxical pulse, and forced attitude and tilting back of the head. Voice changes, it is more corrective for localization of problems in the level of vocal cords. Yeah, you understand why. And one of the first symptoms of neoplasm of vocal cords, yes, is the changing of voice. So stages of laryngeal stenosis. There are four stages: compensatory, stage of incomplete compensation, decompensation, and terminal asphyxia. So first stage, compensatory. Of course, it is better to deal with this stage because you have quite enough time for doing something with this patient. But unfortunately, the symptoms are quite unspecific. Yeah, it is inspiratory dyspnea during physical exertion, reduction or loss of respiratory pause, carbon dioxide content increases, blood saturation with oxygen is stay normal. Yeah, so everybody of you, especially after some physical exertion, may have such symptoms. Yeah, so and of course it's respiratory dyspnea, and it is very difficult to catch a patient on this stage. More often, such patients appears in a clinic on the second stage or third stage. Or, for example, if a patient has changes of voice, also he may appear on the stage of compensation. When he or she still have changes in breathing, but only in voice intonation. So second stage it is the stage of incomplete compensation. On this stage we can see deep respiratory excursion with additional muscles participation, retraction of supra and subclavicular fossa and intercostal space, nose, wings enlarge. On this stage contents of carbon dioxide rises and oxygen level in blood become to decrease. On this stage, inspiratory dyspnea appears during moderate physical exertion, and patients may complain to, for example, from, I don't know, some few months ago, he or she may go up to 5th floor without problems, yeah, but now he or she can move only to 2nd floor, and after this they are required a rest, yeah, to make the breathing better. Yeah? But in in rest, yeah, when the patient is not moved, usually the breathing is okay, yeah, and it is enough oxygen for functions of organism, and it is better to, it is more it is better situation, of course, if we see a patient on this stage. On the third stage, the stage of decompensation. So this inspiratory dyspnea we can reel on the rest. Yeah, it's marked inspiratory dyspnea. It may be stridor, it's retraction of supra and subclavicular fossa and intercostal space. It is steroid cartilage excursion. The patient is nervous, panic, marked pale, cold sweat, acrocyanosis, breath become rapid and superficial, hypercapnia, hypoxemia. Unfortunately, if you deal with patient on this stage, you have quite small time to do something, yeah, because you know that without oxygen, the human being, untrained of course, can live maybe 3 minutes, yeah. After this, usually usually appears changes in brain, yeah, that these changes can be progressed back. And the fourth stage, it is terminal stage or asphyxia. Apathy, drowsiness, fainting, decreasing body temperature, pupils are extended, marked cyanosis, reducing heart activity, respiratory movement are superficial, loss of consciousness, death. On this stage, of course, the prognosis is very, very bad. It's just for you table how changes main indicators of organism during phases of laryngeal stenosis. Yeah, breath movements, pulse rate, level of blood, and level of oxygen and level of carbon dioxide. So what to do if you deal with such situation? If it is foreign body of the airway, start of course from so-called Heimlich maneuver. Yeah. So if it is a child, you may take him, put him on his tummy and make some quick kick to his back, yeah, to make the foreign body removed from the larynx. Sometimes it may be also a variant to make a child vomiting, yeah, because during vomiting also the foreign body may be removed. So clinical manifestation: initial event coughing, choking, gagging, airway obstruction. If this foreign body pass through the vocal cords, it is better variant, but also required quite emergency help. So if the foreign body moves down to may go down to lower airways and fix in bronchus. After this reflex symptom as coughing, choking, gagging reduce, and if the parents also miss this situation, the foreign body may stay in lower respiratory tract for a quite long period of time, and of course it may lead to later yet to pneumonia, atelectasis, and all changes that may be met if you have foreign body in some organ. Yeah, it is obstruction, erosion, infection, fever, cough, hemoptysis. Hemoptysis is when a patient coughing with blood. Yeah. Also remember, so what to do with foreign body? It is Heimlich maneuver. Remember, yeah. And sometimes when Heimlich maneuver is unaffected, you need to provide so-called operation conicotomy. We will speak about it a little bit later. So if the foreign body stay in trachea, we can see such symptoms as choking and coughing of patient, yeah, reflected. How to diagnose? It's due to symptoms and anamnesis, of course, and X-ray examination, and of course bronchoscopy. And bronchial foreign bodies also, if it is the first hours after foreign bodies, it also may be coughing, the feeling of foreign body infraction of chest, X-ray examination of chest may reveal atelectasis of the damaged lung and obstructive emphysema of healthy lung. Also, we can see shift of the mediastinum in the damaged side during inspiration. It's also during X-ray examination. Yeah, it's so-called Holznecht-Jacobson symptom. And of course, if you have some suspicious for foreign body of truncus, such patients require bronchoscopy with removal of this foreign body. If you do it, and of course it is better to do it as early as it is possible, because later this foreign body may strongly fix to wall of bronchus. It may be covered with scar tissue, and it may be some difficult in removing of such foreign body. So false group, it is quite common situation in childhood, and I think that if you have children, or if you will have children, a great number of you will meet with such situation, and you know what to do with this. So what is false group? False group, or other name of this disease, it is acute stenotic laryngotracheitis. It is situation when mucus of subvocal space become edematous and inflammatic. Usually it is caused by viral infection. Usually it is para-influenza virus, but maybe another virus, but more common it is para-influenza viruses. So why it has happened, and why it has happened mainly in childhood? So pathogenesis of this situation, it is edema of subvocal space mucosa, laryngeal spasm, and gland hypersecretion of laryngeal and tracheal mucosa. Why children? Yeah, because children's larynx has some peculiarity. Yeah, so firstly, it is small geometrical sizes. Yeah, you can see that the edema of mucosa in 1 millimeter at adult lead to space for breathing decrease for near 13%, and in the 1-year-old child on 55%. Yeah, so just 1 millimeter, I don't know, I even can't show it. Very small size, very small number. And of course it lead to more severe clinic in childhood than adult. And adult, why in adult it is very rare situation. Of course adult can have para-influenza viruses with edema of subvocal space. Yeah, but due to wide larynx in adult, the adult person will not have any clinic to this. Yeah. Also in child there is abundance of areolar cellular tissue in the subvocal space, and child has high rate of laryngospasm. Triggers factors for false group in child. It is age, from 6 months up to 3 years. Sex, gender, yeah, boys are affected more often, and some premorbid conditions such as acute respiratory viral infection, prematurely born children. Yeah, it's quite often situation in prematurely born children. And overweight, yeah, because in overweight child it is abundance of areolar tissue. False group symptoms. It is barking cough appearing suddenly at night, because the child is in horizontal position that make edema, developing the subvocal space was but removing of inflammatory exudation discharge, the vagus nerve acts at night, and the gas attack. I think that if you sometimes met with this situation, you will not mixed this situation with any other reason, yeah, because it is very specific coughing, yeah, it's so barking coughing, very rude coughing, but the loud of coughing is still present, and it is the differential, one of differential signs between false group and true group. True group, it is diphtheritic group. And really it's mainly appears in at night, yeah. uh, so what to do? The child should be taken on hands, warm drink, try to relax the child, and irritation reflex. No, you understand, well, you understand that not all child, especially when he or she is ill, want to drink in this situation, but what is really important, it is to try to relax a child and try to make their coughing not very frequent, yeah, because during coughing in this situation the edema is increased, yeah, and laryngospasm can happen during this episodes of coughing, and it is very important to try to relax the child. Medically, what to do? First of all, in this situation, no, you can see if the child breathing is not changed for certain period of time, you may just do watching of this situation, give him warm drink, yeah. If you have nebulizer, you can give him just physiological solution to breathe, yeah, to make the air more moisturing. If you see that stenosis is in progress, you must give such patient, firstly, it is intravenous glucocorticoids. It may be prednisolone or dexamethasone or what you have, but glucocorticoids, it is the uh, key drug in this situation, and quite often the symptoms of stenosis reduce during intravenous when you leak this drug intravenously. When you introduce this drug intravenously, it's just remember that the first drug in a case of false group, it is glucocorticoids. Also, it may be antihistamine drugs. It may be dehydrating therapy. It may be spasmolytics. Antibacterial therapy is not very common due to viral etiology of this disease, you remember. Humidified oxygen inhalation if this patient is in clinic. Sometimes in very severe cases, prolonged nasotracheal intubation or tracheostomy may be done, but fortunately, this disease in most cases is not required such traumatic manipulations. Here you can see mixed solution for inhalation, but nowadays in drug stores you may find a great number of drugs for for inhalation, and you're not required to do this mix yourself. But again, I want to remind you that the first drug, it is glucocorticoids. It may be intravenously, and later it may be in inhalation form. So laryngeal diphtheria, also quite important disease, because nowadays, I don't know why, but you may see in net, in internet, in some social networks, quite dangerous activity of so-called anti-vaccinators. Yeah, it is the persons who how to say, who speak, yeah, against vaccination. Really, I don't know why and where they take this information by their presence, and I think that the aim of any doctor to speak, to tell everybody that vaccination is very good and it protect the organism of people against very dangerous infection. And the idea is that somebody may say that there are no cases of such infections nowadays. Yeah, but the fact is that why these cases are very rare, because we still have enough number of vaccination people, and it protect the unvaccinated people from this infection. If the number of people who have no vaccination become to reduce, and we see it nowadays, of course it lead to increasing the number of cases of these infections, and one of the most fresh example, yeah, it is the epidemic of measles in the world. And diphtheria, you know, it is more severe disease, and before vaccination it was the great number of lethal cases from this disease. So remember that vaccination is very important, and all vaccines that are indicated in your country, yeah, must be done. So laryngeal diphtheria. Remember that diphtheria is caused by carina bacteria of diphtheria, and diphtheria passed through 3 stages. Yes, it's dysphonic stage of catarrhal inflammation, and lasts for 2-3 days. In this stage, body temperature increase, appears cough, change of voice, and comparing with false group, and another name for laryngeal diphtheria is true group, and comparing with false group, the changes of voice is very characteristic for diphtheria. The voice become very silent. It is due to action of neurotoxin that produced by these bacteria. Stenosis stage, it is symptoms of laryngeal stenosis appear. It is mainly up to 7 days when membranes formed in larynx, and then asphyxia stage. You may do screenshot of this slide. Yes, it is a differential diagnosis of false group and laryngeal diphtheria. So main signs, yes, it is absence of laryngeal, is absence of vaccination in the case of laryngeal diphtheria. It is changes of voice. It is intoxication. It is coughing. Yeah. In the case of laryngeal diphtheria, coughing relieves stenosis because of removement of membranes. And in a case of false group, barking cough increase the stenosis because of increasing the edema. And remember this slide, yeah, it is epiglottis, acute purulent inflammation, epiglottitis, yes, acute purulent inflammation of epiglottis, symptoms, yeah. Acute pain in throat, difficult breath, high body temperature. It is quite let me show the word proper word for this disease. One moment. Yeah, it is quite insidious disease, and because why? Yeah, because quite common situation, pain in throat, yeah, high temperature. The patient comes to his general practitioner. The general practitioner may observe pharynx and see nothing. Yeah, because to see epiglottis, you need to do yeah, indirect laryngoscopy to see epiglottis. Yeah, or in other case you need to do X-ray examination. In many cases, general practitioner will do nothing in this situation and administer some symptomatic temperature. Yes, it's non-steroid anti-inflammatory drugs and let the patient go. But of course, the patient situation may become better during this treatment, but sometimes it is not enough, and the patient returns with stenosis. Yes, due to increased edematous epiglottis. Yeah. Sometimes we can see here the pus that is localized under the mucus, yeah, and in this case we need to drain this pus. So just remember about this disease, and if you see that something wrong is with this patient, and especially if such patient has difficulty of breathing with these symptoms, yes, with acute pain in throat and high body temperature, remember that it may be epiglottitis. So what is tracheostomy? Tracheostomy is the opening in the anterior wall of trachea and introducing in and converting into a stoma with a skin. Yes, stoma, it is operation when we suit the mucus of some organ to the skin. So what are the indications to tracheostomy? It is laryngeal stenosis in second, third stage, prolonged artificial lung ventilation, and due to these indications, I want to add such situation with when a patient has strong facial trauma, yes, when it is impossible to intubate, to make intubate the patient, yeah, due to oral cavity, through the oral cavity or through the nasal cavity. It also can be met. So tracheostomy types, we divide superior, middle, and inferior depending on what ring is between what rings the hole, the foramen is done. So in this picture you can see tracheostomic tube. Yeah, it is quite modern type of tracheostomic tube. You see that this tube has two cuffs, and it is very comfortable for a patient and for doctor, because yeah, we speak about it. Yes, if we have this cuff insufflated with air for a long time, this cuff press to the walls of the trachea and may lead to chronic inflammation of mucus, and then it may progress to scar tissue formation and stenosis of trachea. That's why was suggested the tracheostomic tubes with two cuffs, when you may insufflate these cuffs periodically. One cuff, then other cuff. Yeah, so these cuffs are insufflated periodically, time by time. Then one cuff, then other cuff. What may be the complications of tracheostomy? It is reflex cardiac arrest, bleeding, subcutaneous emphysema, pneumomediastinum and pneumothorax, formation of false passage, injury of anterior wall of esophagus, shock after hypocapnia, pulmonary edema, purulent tracheobronchitis in postoperative period. The most common complications are, of course, bleeding, subcutaneous emphysema, sometimes formation of false passage, very rare injury of anterior wall of esophagus, and purulent tracheobronchitis in postoperative period, especially if this tube is functioning for a long time. Yeah, because you understand that breathing through this tube is non-physiological, and only breathing through the nose, the air is humidified, cleaning, yeah, and protected with mucociliary transport system. Of course, if a patient has breathing through the tracheostomic tube, all these functions are switched off. And of course, it is better and to do everything to return the patient to normal breathing. And conicotomy, yeah, remember, yes, it is incision and cutting the conic membrane that is localized between thyroid and cricoid cartilage. It is it is considered the most emergency entrance to airway tract. And if it is possible, of course, it is better to start from laryngeal intubation. It's a tracheal tube. Here you can see pictures of post-traumatic laryngeal stenosis when the patient has some prolonged injury of larynx. I think it is due to prolonged intubation, and you see very small hollow for breathing due to formation of scar tissue. And here you can see the complication of foreign body of esophagus. Yeah, it may be a situation when foreign body is localized in esophagus for a long time, or not for a long time, but in a patient who have some problems with health, for example, diabetes mellitus. And in this case, the foreign body may make a trauma of esophagus with perforation, and infection may spread to spaces of neck, yeah, for with formation of neck phlegmon and cervical mediastinitis. And in this case, of course, pus, edema, press on trachea, press on larynx, and make a narrowing of these organs. No, and again, to remind you, main 10 emergency cases in ENT. On this, we end our lectures. Thank you for attention. If you have some questions, you may write here. I want to remind you that the presence on all LA on all lectures will give you additional point to your final mark. If you now have a question, think about this, and we can speak about all these questions during our practical lessons. So if you have no questions, thank you again for presence, for hearing. Good luck. Wait you for another lectures for our discipline. Goodbye.